allowing me to be participating today. It's good to hear and talk to many of my friends that are getting through the disaster we're currently in. So again, it's a pleasure to be here today. I was asked to talk on 3D printed fusion implants, realizing that I'm neither a biomechanical engineer or a molecular biologist, but I do use them clinically in my practice, and I think it is the current future in spine surgery, and we're going to primarily look at lumbar interbody implants. If we look just to get from how do we go from there to here, if we look at lumbar fusion surgery in 20th century, certainly was a mixed breed that, you know, I initially in my training started working with the Lukey triangle and then went to pedicle screw fixation. It was really a rough road. We didn't understand what we're doing. There's massive tissue destruction. In the 60s, Roy Camille was really ahead of the times. He developed the concept of Spinal Center for Acute Spine Trauma. And in 1979, he presented his paper at the AAOS regarding pedicle screw fixation. Shortly after that, we really entered what I would call the decade of pedicular madness. Spinal surgeons were looking for a definitive answer to painful spinal instability and the unpredictability of our current techniques. And what did we find? That despite this, a posterior loan operation had 20 to 30% failure rate of fusion, depending on how many levels were done. And it really was quite awful. And given that, we started moving to a global spinal fusion, anterior-posterior procedures. And the question is, by going to AP fusion, well, that's the answer our poor results. Well, in Spine 2000, a large series looked at this, and by 5 months doing an AP fusion, we really had 100% fusion rates. But what do we find from that? That unfortunately there was a weak correlation between fusion and clinical outcomes, most likely because we weren't paying attention to things. We're doing massive tissue destruction in these patients. We weren't looking at global alignment. We were destroying the adjacent facets and resulting in increased degenerative disc disease at the adjacent segment. And then also a lot of the techniques we're doing, I believe, was increasing our pseudoarthrosis rate, ultimately our fusion rate. Initially, the interbody material was autographed. It certainly works, but some of the problems with autograft is the more we look at it and the more honest we are about our own results, there is significant surgical site morbidity. Certainly, I think we all know that when we were using harvesting autograft for ACS, anterior cervical fusions, patients always would come and complain about their graft site more than anything else. And the other thing is, it certainly required a lot of carpentry to get the right fit. And finally, there is a lack of immediate stability unless there was significant adjuvant spine fixation. Because of that, we did go to structural allografts. Problem, once again, biomechanical variability. There was graft reabsorption. Back then, we called it settling, but it's really subsidence. And then also, disease transmission certainly occurred. The next stage in our evolution was going to synthetic cages, primarily titanium, first stainless steel, then titanium, then PEEK. Obviously, the drawbacks were increased cost and loss of biologic activity. Oops, what have I done here? And here's just a quick table of looking at some of the interbody devices from the 40s to the current, and it really is a huge area of investigation currently. One of the big changes after I finished my training was the BAK Cage. And we were using it as a standalone device, and we thought this was just a fantastic idea. And certainly there was immediate post-operative stability, but what did we find in looking back on this? That our revision rate was over 30%, and 75% of the patients really did not improve. Why is that? Well, our surgical technique, see on this x-ray, we were violating the end plates purposefully to thread these cages in. That was resulting in significant subsidence and failure rates. Therefore, one of the big debates in my early days when we were using stainless steel versus titanium primarily is we had so many failures, we didn't know who had a pseudoarthrosis if they're hurting from something else. And back in those days, what did we do? About 12 months after the original surgery, the index surgery, we would go back in to remove the hardware, which really doesn't make any sense. And certainly we found there's a 30 to 40% mismatch in what we found in surgery and what we thought we're going to find going in based on radiographic X-ray. So this is certainly less than ideal just from a radiologic investigation standpoint. So that's when we went to polyether ether ketone, primarily to improve X-ray visualization. The PEEK also has an elastic modularity of elasticity similar to bone, so it seems to fit fairly well. And that was certainly, for the past decade, has been the primary interbody fusion, certainly in the United States and most likely around the world. Now, what have we found about that? That there does, on many patients, a fibrous encapsulation occurs, biofilm that prevents osseous integration, and indeed can be a trigger for infection as well as a pseudoarthrosis or failed fusion. If we have a failed fusion, I think that it increases the risk of subsides and poor results. And because of that, we've slowly been returning titanium, or maybe not so slowly. Now, the X-rays here certainly wouldn't blame this subsidence completely on the type of implant. Looking at it, I think that we have to realize there's surgical technique. This is an oversized implant, probably some end plate damage putting the implant in. Those are all things we need to consider. So when we went to titanium, back to titanium, we started looking at other specialties. And over 20 years ago, the dental surgery realized that by roughening the titanium, it really increased the osteo ingrowth and the osteobiology of the implant. And we started about 15 years ago, we started, spinal surgery really started looking at this. And as sort of a hybrid look at that, a lot of people have been using titanium coated PEEK. And some of the issues with that, it gives excellent X-ray visualization. However, I think there is a delamination risk. The implant itself is unchanged. So once again, I don't think we get any more biomechanical stability than we do from the original PEEK implant. And as I already mentioned, there's studies that shown that there's delamination occurs during impaction of implants. And the FDA has recalled some of these, a couple companies of this. However, it's not just this. The 3D printed titanium implants can have issues as well. Because if the algorithm that this whatever companies use is making is not optimized, we can see failures. And indeed, the FDA has recalled several companies' cages that were really suboptimal in their design. One of the things that I have a little bit of experience in the cervical spine, but not much in a lumbar spine, is porous PEEK or textured PEEK, where there's a processing of the edges of the PEEK. And animal studies have shown that there is osseous integration, probably only a millimeter or two inside the textured PEEK, but that does allow for osseo integration. Obviously, there remains a very easy revision strategy for these cases, which is always an important thing. And then finally, the X-ray visualization is quite good. But once again, it relies on the grafting material we used. There's no improvement in load sharing. Subsidence risk still remains high as well. So one of the things we want to look at when I think of these titanium implants, I'm always looking at the material as well as the surface technology. And one of the nice things about 3D printed porous titanium, it allows for extremely variable geometry, so we can dial in the architecture of the implant so it mimics cancellous bone, or the modulus of strength is between cancellous and cortical bone. So to improve cage performance, 3D printing, it certainly, in my opinion, some of the studies we'll look at, does improve, osseous integration. It does, I believe, improve mechanical properties we'll see, and maintains good imaging integrity. There's multiple animal studies that have looked at implanting PEEK versus 3D porous titanium. And you can see on the upper right-hand study how those titanium implant is completely osseo integrated. And you can imagine how that's a much more stable implant than the smooth PEEK. As we get bone ingrowth, it improves functional osseous integration, or increases the maximum shear stress and biomechanical stability of the bone implant interface. And here we can see with the 3D porous titanium compared to other types of titanium and others end plate structures that we're currently using, that this maximum shear stress is really quite significantly improved over other types of materials. And this is obviously not a lumbar interbody fusion, but it's a case I did probably about over 10 years ago that really illuminated to me the power of titanium etched implant. This is an SI fusion I performed on a 70-year-old woman who was osteoporotic. She left the hospital after an overnight stay. When she got home, she had a fall going downstairs and developed immediate right leg pain. We got x-rays later that day that showed the upper implant had migrated and was now pushing on the L5 nerve root. I told her we really need to go back. She delayed, and about 3 weeks, maybe it was more like 4 weeks after the fusion, because the pain was so severe, she decided to let me go in to remove this. I thought that within 3 to 4 weeks of surgery on an osteoporotic female, to be able to just pluck this implant out. We got down to the implant and it would not budge. You can see there, I had to chisel along the edges of the implant to remove it. And on the back table, you can see this hunk of bone, osseointegrated bone, that I could not even remove off the back table. So even though this failure really indicated to me the power of the titanium etched implants early on. Now, we already, the last talk, discussed very well what titanium 3D printing is. Basically, it's just a titanium powder laid over a building plate, high-powered laser, computer controls the appropriate design, and layer by layer fused to each other. Well, multiple plates multiple implants can be placed at one time on a plate. The real clinical problem is that post-processing is necessary to finish the implants. I think that's going to be one of the things that's going to limit being able to do this in an individual hospital, as well as more complex implants that are coming out now. There's multiple 3D parts that then have to be reassembled separately again in post-processing. But again, as I mentioned briefly earlier, that by tuning the implant, by getting the internal geometry of the implant, what do we find? That we can get this porous titanium alloy to be really between cancellous and bone. So we have really a very true physiologic interbody implant, which will hopefully decrease end plate stress and subsidence, will continue to stress shield the graft aperture, or unshield the graft aperture, I should say. So we did a clinical study using a 3D titanium implant. And this is a prospective study that we took all patients coming in. We used the implant modulus, which again has end plate architecture that mimics the porosity of cancellous bone, which I do think is important, as well as the internal design. And this is just showing how this implant on a sheet model allows for osseous integration by 12 weeks, complete osseous integration in this particular animal study, which obviously improves the biointegrity of the bone end plate interface. And again, as we do more and more design optimization, we can change that internal cytoarchitecture of the end plate so that every different size and angles, 0 degree, 10 degrees, 15 degrees, whatever it may be, is optimized for every implant size. So in this particular patient group, we had 72 patients we enrolled. They were actually not healthy patients. They had almost at least 3 significant comorbidities. Almost 60% of the patients had a deformity. We treated a total of 143 levels. And if we include an ALIF or a hyperorthotic level, patients did have a peak implant because we did not have anything to 3D implant that could treat those levels at that time. And a posterior procedure, either adjuvant fixation, posterior decompression, or both, was done in 75% of the patients. And I think our results are actually quite good. Very reasonable EBL given that the deformity cases, as well as the OR time. The postoperative stay was a little bit less than 3 days actually. No significant intraoperative complications or postoperative complications regarding the surgery. And 68% of the patients at 7 months showed a solid fusion on a CT scan. There were no reoperations. The 12-month VAS score was really quite good, I think. Here's just a typical patient. It's nothing complex. It's a elderly woman with neurogenic claudication and low back pain who can fail conservative therapy. You can see she's got a grade 1 spondylolisthesis with L4-5. Her preoperative parameters showed relatively good sagittal balance with a 10-degree mismatch, but really, in my opinion, was not a deformity case. The MRI shows, once again, moderate severe stenosis at L4-5. The sets were fairly open. And looking at the Psoas muscle I thought was quite favorable anatomy without a very anterior plexus. And my thoughts were if we could reduce this, we could probably get indirect decompression without having to do a posterior decompression. And you can see the intraoperative x-ray over here that shows good visualization. Now in this particular case, this woman really did have a quite small footprint of her spine. And you can see that implant is right on the anterior edge. I don't think we ruptured the ALL, but I'm sure we thinned it out a little bit. And then ultimately, I felt that there was still a little bit of a slip off, but we didn't get a complete reduction. So I did go ahead and do a posterior reduction at the same time. Now here's the post-operative scan at 8 months showing not only bone growth through the aperture, but also there's bone growth posterior to the implant that we can see. And there's really no scatter from the implant. So it really allows us to visualize bone fusion very, very nicely. And so if we compare this newer 3D printed implant with more of the solid titanium, you can see on both X-ray and CT scan, we get excellent visualization, allows us to track the patients for radiographic study. One of the problems we had, or one of the things I was really looking at is what is the degree of subsidence? And this is the one patient came up that I thought had subsidence. And you can see it was a very mild coronal deformity. At 9 months post-op, she had an excellent reduction of the VAS, but without a true en face view, you can see that lateral x-ray. It's hard to say, but I think we're actually looking at the implant in an oblique view. Realizing that, again, as we all know, that the subsidence can be difficult to quantify and certainly age-related, the degree of osteoporosis, are we doing one versus multiple levels? Is there an ALL release? The degree of facet arthrosis, all is very important. Our intraoperative technique, did we damage the end plates? And is there a difference in impaction versus expansion? Certainly we don't have those answers yet, but I think that down the road we will get those pretty quickly. And here's this patient, we actually got a CT scan at 2 months, and I'm really not convinced on this that she did have any subsidence. I think that the plain x-ray just was looking at an oblique angle. So let's go quickly talk about grafting for this. So what did I use for grafting in this study? Well, basically what we would do is get bone marrow aspirin. We use the same technique that Dr. Patin did in the study that Dr. Hartle mentioned earlier, where we process and get 10 to 20 cc's of bone marrow concentrate, essentially, with concentration of colony forming units. To get it on the back table, I'd size as early as I could. I'd put the implant in, it would actually wick the bone marrow into the end plates, complete my discectomy, and then we could go ahead and put the implant in, realizing that I had, I think, an excellent substrate to allow for good bony fusion. One of the other things that we have seen on using these titanium implants is it allows an easy observation on X-ray, the end plate mismatch. The question is, should we be a better carpenter? I'm not sure that's the answer because we have not seen any clinical relevancy to this end plate mismatch we see on X-rays. I think it's really just an aesthetic problem that we see as surgeons when we look at our own X-rays. On the other hand, down the road, maybe we will see more of a domed implant on that inferior end plate surface of the bone, but that's going to be more complicated. Again, should that be an expanded versus an impacted implant? Regarding additives, which everybody's now starting to talk to, these companies want to pre-package their implants with their own grafting material. And I think they're certainly going to be, depending on cost and availability, DBMs, BMP are going to be put in, ceramics, stem cells, whatever your definition of stem cell may be. One of the debates right now on 3D printed implants, do we want the surface to be charged either positive or negative in order to attract osteoblasts and stimulate the osteoblasts and the osseous integration? And I think that's still, the debate is still out on that question. So in general, I think this is probably the most important reason I think there's clinical advantage to 3D printed titanium implants. By allowing for this excellent osseous integration, will there be less of a requirement for grafting? I think so, and that will certainly be a decreased cost to the hospital and the patient down the road. And eventually, we're going to see smaller and smaller graft apertures to the point that they're essentially non-existent other than having some to allow for easier radiographic investigation. If we can close off those graft apertures, maintain the same dimensions, it's going to improve surface area and load sharing. If that occurs, we should see decreased subsidence. which I think in our early study, we saw indications of that, as well as we would hope a better fusion or a faster fusion, which obviously we don't have the data to support that statement entirely. And for those of us that are involved in developmental processes, the more metal that I can keep in my implant and allow for osseous integration, the more metal I can give the engineering team to work on, I think the more novel things they can use, and this is an implant that's not available yet, it'll probably be another 6 months, but by using 3D printed, a lot of titanium available, they're able to get expansion both anterior and posteriorly independently. What does that allow? It really allows for not only an infinite degree of distraction, but also the lordosis. I'm very excited about this for the future. So in conclusion, I certainly believe that surface textured 3D printed implants may result in earlier healing. There's more research to go, realizing we still have to be good carpenters. We have to understand that we have to minimize tissue destruction. We have to maintain global alignment. Our surgical techniques have to be pristine, and we have to be honest about what we're doing as we're improving our materials and biologics, as well as changing implant technology. And with that in mind, I think I'll stop. It's getting late in the day. Thank you very, very much.
Very great talk, Bill.
Thank you.
We're going to open for questions.
Yeah, hey, it's Roger Hartle.
Yes, Roger.
Yeah, I want to give you an update. I'm actually going to get dinner tonight, and it's okay. You know. And I was going to ask you. So if you had to define like the advantage of 3D printing technology, like in a sentence or 2 sentences, I mean, what does it really mean for a surgeon? What's the advantage of 3D printing versus like regular manufacturing?
Well, I think the 3D printing, it allows the manufacturer an infinite number of possibilities. And what does that mean clinically? It means that you can have, it's easier for them to make more individual sizes. So we just don't have 3 sizes, a small, medium, and a large. But really more importantly, it's this osseous integration we're learning more and more about. I think that's what's going to change what we do more than anything. And by having, again, a larger surface area of this osseous integration, I'm expecting to see continued evidence of decreased subsidence, increased fusion rates, and hopefully a quicker fusion rate, not the decline in the fusion rate, but a quicker return to normal for our patients.
Bill, may I ask a question? Bill.
Yes, sir.
Great talk as always. You know, we have been working together the last 15 plus years. And we were super happy with our BAK cages. And we would say and talk and give advices saying, oh, BAK is the best implant. We can see our fusion and the result is great. The first typical question is why we changed from BAK to titanium when everything looked good at that time. Second question is, we know that 3D printing is an adding technology. In the new company I'm working, we are working in a porous titanium cage that is adding technology. So we can more regularly measure correctly the porous connections, and looks like maybe, we don't know now, maybe the growth, the bone growth, when you really have the porous continuity, could be better for the future. But what I want really you to describe is why titanium, and don't you think that doing surgery with titanium and bone, you get confused if the end plate and the cage interface looks good, because usually those doesn't look good.
Yeah. Those are great questions that'll probably take me about an hour to answer, and they still will be an incomplete answer. So, why do we go to PEEK to titanium, or why are we in that process right now? I suppose one simple answer would be these companies need to make money, and it's how they do it, to be honest.
For sure.
But I do believe that it's the osseous integration and the growth through the implant itself is going to change what we do around the edges. Now, as you remember, 15, 16, 17 years ago, what was lateral surgery? What we were told that we were doing such a poor job. We started seeing subsidence and measuring this. And everybody said, oh my God, subsidence. Now, the truth is, compared to T-lift or PLIF or P-lift, the lateral surgery was also always had a much better subsidence rate, just that all of a sudden we noticed it and started talking about it. And so I think that we're trying to fine tune the edges of our surgery that we do. And if we